Melbourne Integrated Cancer Service, and welcome to the NEMICS Annual Forum in its new format. We're all learning on our feet these days. I'd like to begin by acknowledgement to country. I'd like to acknowledge the traditional owners of the lands where we are hosting this webinar from, the Wurundjeri people of the Kulin Nation, and the traditional custodians of the various lands on which you all work today at your various offices. I pay my respects to these people, their culture and their traditions. I pay particular respect to their elders, past and present, and any other Aboriginal people on the webinar today. We will begin by hearing about 3 pieces of work that are currently underway within the NEMICS program office. Together, these projects are being presented by NEMICS staff, but of course there are a whole lot of other people who've contributed to this work in terms of clinical people at the various hospitals and health service staff. There will be an opportunity, fairly brief, to ask questions following each presentation. Please submit your questions using the Q&A function on your screen. Our keynote presentation for today's annual forum is from Professor Jane Phillips, who I believe is linking in from a rural setting in New South Wales. And she's going to explore the issues affecting the older person with cancer, focusing on how we can identify those patients who require more support. This is becoming an increasing problem in terms of the aging of the population and an increasing proportion of the population of people with cancer who require support. There'll be an opportunity to ask questions throughout the presentation, once again using the Q&A function on your screen. We may not get to all the questions during the forum. If we're unable to get to your question, we'll endeavour to answer that during the session or shortly afterwards. Now, the first presentation is from Nadia Ayres, who's one of the NEMICS staff. She's been with the team for over 10 years, and she's been working particularly focused around the optimal care pathways, putting these into clinical practice. She is going to share the results from one of our OCP service improvement projects that go back to 2018 in relation to the Head and Neck Cancer Tumour Summit that was held here in Victoria. The project began shortly after the summit, where a small team from the Austin Head and Neck MDT were involved, and we were assisting them to understand and address local issues, and that was particularly around delays in delivery of radiotherapy. Nadia, I'll pass now over to Nadia to present this work.
Thank you, Paul. This project began with the Head and Neck Summit a couple of years ago. The data presented at the summit had indicated that only 35% of NEMICS patients with head and neck cancer received care according to the optimal care pathway recommendation, which is to start post-operative radiotherapy, or PORT, P-O-R-T, you'll see on the screen there for short, within 6 weeks of cancer surgery. So after meeting with the Austin team and reviewing the pathway of care, the data and the feedback we had from patients, here's a summary of what we found. The Austin Head and Neck Cancer team felt that patients needed to be listed earlier for their MDM discussion. Referral to a radiation oncologist needs to happen as soon as the need for PORT is even suspected. Referrals from surgeons in the MDM need to reach radiation oncology quicker. And most importantly, radiation oncologists need to see their patients without delay to begin planning their treatment. The local data we analysed indicated that most patients were taking between about 8 to 9 weeks to start their radiotherapy, and they were often delayed in their need for PORT being identified early in the MDM, being referred to a radiation oncologist, and in having an initial consult booked with a radiation oncologist. And generally, each of these issues impacted the delay by about a week. Similar themes were coming through from patients and carers. Patients wanted more information up front about their disease, find it difficult not knowing what to expect, and just felt much better once a treatment plan was in place. Clearly then, our aim was to try and fall in line with what the evidence and the OCP recommends. It should only take 1 day from MDM to referral, 7 days from MDM to the initial consult, and overall, a patient should start their radiotherapy within 42 days of having curative surgery. So with this in mind, we decided to focus our efforts on improving the early part of the pathway. The team decided that an expedited referral process from MDM to oncology would be developed. We would document the pathway of care as a reference for surgical registrars who action most of these referrals, so they're well informed about the process. Radiation oncology would arrange for a consultant to see new patients in the clinic to speed up the first appointment, and oncology nurses would be routinely included in the referral process to enable early support and care coordination assistance for patients. The main tool we developed to support the new referral process was this expedited referral form you can see on the screen there. The form's designed to ensure that all of the key information is passed on to initiate the referral and prevent delay. Details such as what treatment is being considered, pre-testing being organised up front, the MDM outcome, clear diagnosis and staging information, the surgery date to be able to monitor the 42-day timeline, and if a patient has significant comorbidities that need to be made aware of, are all communicated as part of the referral. While the expedited referral form's been in clinical use now since March this year, and so far the results are looking pretty promising. The data I've examined so far shows that 13 patients received PORT between April and June this year and took an average of about 42.7 days to start their treatment, which is in line with the OCP recommendation. It also looks like the time taken for a patient to move from MDM to referral and then be subsequently seen by a radiation oncologist have improved and are also on target. And then looking at the results overall, the time taken for patients to start their radiotherapy after head and neck surgery is coming down almost routinely now to less than 42 days, which is really encouraging. So just to quickly wrap up, perhaps the new expedited referral process appears to be making quite a significant impact on ensuring head and neck cancer patients at Austin start their radiotherapy within the recommended window of 6 weeks to ensure optimal care and best outcomes. And just a big thank you to the Austin team and the patients who shared their experiences at the Head and Neck Summit. Thank you. Back to you, Paul.
Thank you, Nadia. There's been a question here. Are all patients discussed at an MDM from Anonymous?
All the patients that come through the surgical team get discussed at the Head and Neck MDM. Yeah, they do.
I think that's the only question I have at this time. Thank you, Nadia. It's tremendous, and it's tremendous seeing that continual improvement. And it's often through no one's particular fault that these delays occur, but it does mean that if we tweak the system, we can really improve things quite dramatically. Thank you.
Thank you.
Now we move on to the next brief presentation. This has been presented by Llewellyn Teck, who's a project lead for the regional service planning for NEMICS. She has other project roles that include working also for the Head and Neck Tumour Summit and was service improvement facilitator at Eastern Health for some 10 years. Llewellyn's presentation is an update on improving delivery of population-based cancer care in the region. This has been a focus of the NEMICS planning workshop last year, and many of people in the region, including, I would imagine, a number of people on this call and webinar, contributed your time and expertise to work on this. I will ask Llewellyn to step forward.
Thank you, Paul. Good afternoon, everybody. Over the last 10 months, the NEMICS Program Office has been working with our network partners to improve self-sufficiency. And I'd like to open by acknowledging our partners for their assistance in this work. Self-sufficiency measures the rate at which residents of the NEMICS geographic region access services within the region. And NEMICS has the lowest self-sufficiency of the Melbourne Integrated Cancer Services. In 2017-18, 34% of our population received their care outside of our region. So we hope to address this by improving access to local cancer services. We reviewed data and collaborated with you at the Regional Planning Workshop in October last year to identify ways to improve access to high quality cancer services closer to home. Graham Down, a member of the NEMICS Consumer Reference Group, shared his experiences and insights gained during his treatment and diagnosis. Consumers tell us that they favour care close to home. However, there are often good reasons that consumers do receive their care outside of their local region. Health service representatives presented their activity data and informed us of changes in their service capabilities over recent times. And we identified the top service planning challenges and the desired future state for delivery of cancer services in our region. Together, we identified opportunities for each health service and for the region, and 3 areas were identified for region-wide action. One being cancer care coordination, the second being specialist programs and referral pathways, and the third being care outside of hospital. The NEMICS Program Office has worked closely with consumers, service providers, clinicians, and the Eastern Melbourne Primary Health Network to help shape the region-wide scoping projects. Under cancer care coordination, we reviewed local data for disadvantaged groups and consulted with health services and clinicians to identify the priority areas for improvement. Following this, a decision was made to focus on the coordination of care needs for older people with cancer. Patient experience data and cancer clinicians informed us of a range of challenges experienced by older people with cancer, and they often include things such as coordination of transport needs, making telehealth work, access to allied health services, coordinating cancer and comorbidity care, and managing communication and integration across acute and primary care sectors. So we have developed a guide to aid with establishing care coordination initiatives and evaluating and sustaining care coordinator roles. Further work on improving care coordination for older people is planned in the coming months, so keep watching. Specialist programs and referral pathways. We engaged with consumers, clinicians, and the Eastern Melbourne PHN, and we reviewed data to identify 2 specialist cancer types to focus on, and we chose myeloma and rectal cancer. We chose myeloma because it's an increasingly prevalent cancer in the community and will have an impact on health service capacity into the future. Myeloma is a chronic, lifelong disease, and with most care provided in an ambulatory setting, patients can endure ongoing appointments and treatments spanning many years. Rectal cancer was chosen because it's a high volume cancer, and most of our health services in the NEMICS region, both public and private, provide rectal cancer services. Treatment usually involves multimodal interventions, and therefore multidisciplinary treatment planning and care is particularly important. We sought consumer and clinician input to better understand why people choose to have care at certain hospitals and to understand the existing referral pathways. And the health service clinicians that we spoke to were keen to increase referrals of myeloma and rectal cancer patients to NEMICS Health Services. Consumers told us that they would like to receive treatment in a hospital closer to home, to enable family to visit, to share their care, to be closer to public transport, and with the possibility of better access to car parking. So in the future, we're planning to do some more focused work in the coming months in the Specialist Programs and Referral Pathways project. Care outside of hospital. access to home-based cancer care can improve the patient's experience for certain groups. It can reduce patients' anxiety related to accessing and receiving care, and particularly for the elderly or frail, and provides better opportunities to inform and educate patients in self-management. The Department of Health and Human Services released a home-based cancer care framework and toolkit in May 2020. Health services are currently assessing their home-based care services against the toolkit, and they're considering additional patient cohorts that could have their care delivered outside of the hospital. Eastern Health have already transitioned a number of treatments from the day oncology unit into the home-based cancer care setting. NEMICS will facilitate a workshop on home chemotherapy and other opportunities for home-based care in our network if our partners desire it. Sorry. And on behalf of NEMICS, I'd like to thank our consumers, health service staff and other partners for their valuable contributions into these projects. Thank you.
Llewellyn, could I just ask you, so as I understand, the NEMICS has created a guide that is related to funding for care coordinators and ongoing challenges that we have in that space. Sorry about the background noise. Could you speak to that?
I'm sorry, Paul. Could you repeat the question?
Sorry, it's difficult because I've got so much noise there. Yeah, funding for care coordinators is an ongoing challenge, and often this kind of function is needed, particularly in complex tumour streams. As I understand it, we do have a guide that NEMICS has created around that.
Right, yes, sure. Yeah, as we know, funding is always a challenge for these roles, and I'm sure that will continue to be the case. But in terms of the guide, it will provide, there's been some work done, there's been review of some successful models and sustainable models, both locally and further afield. So the guide contains some information around those successful models, and also it contains some tips on how NEMICS can assist health services in achieving a sustainable model. So there's ways through data and data analysis, some guidelines around working on your governance model and what the scope and interventions of the role should be. So we're hoping to have a release of that shortly. So it will be, there'll be some notification around that in an upcoming NEMICS newsletter.
Thank you very much for that, Llewellyn. Our next speaker is Lena Elkman, another member of the NEMICS team. Lena had completed the Master of Public Health and has had significant experience in projects with the Cancer Council here in Victoria, blood cancer in the United Kingdom, and with us here at NEMICS over the last 3 years. Lena has been involved in a pilot study around encouraging earlier referral to specialist palliative care for people with cancer.
Thanks, Paul. So yes, I'll be speaking about the referral processes to palliative care project at NEMICS. So early referral to specialist palliative care has demonstrated benefits for people with cancer. It can improve quality of life, ensure patients are more likely to die at home, and even improve survival rates. It of course addresses severe symptoms and can reduce the amount of aggressive end-of-life care that is given. And so this issue around potentially late referral to palliative care was raised at both the lung and pancreatic Victorian Tumour Summits. And so the current project's aim is to increase the number of people with metastatic or progressing cancer who receive an appropriate and timely referral to palliative care. So at the start of this project, we did some scoping work. We looked at the literature, and there are known barriers to referral, particularly around perceptions that palliative care only becomes relevant at the terminal phase. Interestingly, there's no agreed definition of timely or appropriate referral to palliative care. We spoke to local stakeholders, so both patients and clinicians, and anecdotally there is evidence of late, missed or inappropriate referrals. There was unanimous agreement by our project steering group that referral should be based on need rather than prognosis. We also looked at data, so large data sets like the Victorian Administrative Episodes data set were a bit limited in what we could see around referrals, but we did some detailed medical record auditing, so audited over 250 records and saw that over a third of patients only received their referral to palliative care in their last 30 days of life. And we couldn't see any standard process of identifying patients in need of a referral to palliative care. So the project steering group has helped us guide 3 main action areas. So the first being around a standardised needs-based assessment to ensure a timely and appropriate referral to palliative care. The other is around communication skills. So we acknowledge that palliative care and end of life is a hugely complex and tricky topic to discuss. And so there are some important skills that could be developed in that area for clinicians, and just general awareness raising of what palliative care services provide so that, so to encourage a referral to understand those benefits. So in terms of the standardised needs-based assessment component of the project, and that's what I'll focus on for the remainder of the presentation, there are existing tools out there. So we came across one developed by the Royal Marsden in the UK called the Triggers tool, which is oncology specific. And so one clinician at an Eastern Health oncology clinic out at Yarra Ranges agreed to pilot this tool for 3 months. So the tool itself lists the Marsden triggers, as I mentioned. So for example, metastatic cancer progressing after first-line treatment, severe or overwhelming symptoms, moderate or severe psychological or existential distress, and then also incorporates an assessment of prognosis to ensure that the patient is referred either to the community or to the in-house hospital team if required. And so results, across the 3 months, there were 55 unique non-curative patients screened. Interestingly, 32 of those were actually eligible for referral, but only 5 went on to accept that referral to palliative care. 5 people were already linked in with the community palliative care team. There were 2 that were admitted on the day of being screened, and 20 went on to refuse the referral. And so the sorts of reasons why patients were refusing were pretty consistent. They felt quite well supported, they were coping well, they had stage 4 disease for a while, and they weren't ready to engage with the palliative care team at that point. In terms of the referral rate, so we saw a small increase from 11.4 to 13.6% at baseline to the compared to the pilot. In terms of timeliness, interestingly, the number of days between diagnosis and palliative care referral, and then the number of days between palliative care referral to death, actually looks worse in the pilot sample compared to baseline, but this needs to be interpreted with caution given that the numbers are so small. It's a small sample size. In terms of qualitative feedback, so speaking to the clinicians involved in the pilot, they reported it did encourage reflection about the subconscious hesitancy to refer, and it was important that there were several patients that accepted the referral after initially refusing and then being screened multiple times. This clinic where we tested the Triggers tool is quite unique. It has good supports in terms of all patients see the same clinician each time, the same oncologist, and they've also got an oncology specific social worker on site. And we thought that could be a potential barrier to accepting a referral to yet another service. And so these results seen here may look different if we were to test it somewhere else. So in summary, we saw a small increase in referrals through this pilot compared to baseline, and there are some likely biases from the clinic that we chose to test the tool. Those refusals and then subsequent uptake by patients highlights the need for repeated early introduction to the concept of palliative care to understand its benefits. And so our next steps for this project, we've refined the tool and we are planning to roll that out more widely at other sites to improve referrals. And importantly, in combination with the other initiatives I previously mentioned, so the communication skills and general awareness raising of the benefits of palliative care. So just a big thank you to everyone involved in this project, particularly those names highlighted in green, who are the Eastern Health pilot team. Thank you.
Thank you very much, Lena. I don't think we have any specific questions, but could I ask, in terms of the tool from the Royal Marsden, the UK, was used rather than some local tool? Is there a particular reason for that?
It really just came down to it. One of our clinicians on our steering group had mentioned it. I think they'd seen it at a recent international conference, and it is oncology specific, not all of them out. There are other validated tools out there that are more general, and some of them are more like 2 to 3 pages, whereas this is a 7-item quick, you know, so in practice, at a practical logistic level, that was seen as more user-friendly for the clinician that agreed to test the tool.
There's a question from Karen. Can you say a bit more about the types of communication skills you refer to on the slide, and for whom?
Sure. So the communication skills is for, it'll be for anyone who's working in cancer in terms of medical, nursing and allied health staff. So the Cancer Council Victoria actually has an existing program. So we were planning to run this face-to-face pre-COVID. Obviously, they have a paid actor, and they do. It's quite an interactive session. We are looking at delivering that to a small group virtually as a test, just given the current situation. So yeah, hopefully that'll be a good an interactive session despite those challenges.
Thank you, Lena. We're now coming to the keynote presentation for the forum, and they have the opportunity now to hear from Professor Jane Phillips. Jane is going to explore how we better meet the specific needs of the older cancer patient, both in terms of our identifying the sort of support that might be needed, but also around how we might better set up our cancer services to cater for the older patient. Jane is Professor of Palliative Nursing and Director of the IMPACCT group based at the University of Technology in Sydney. She has skills in cancer and palliative care, clinical nursing, and she's applied that expertise to a range of patient-focused studies, including clinical trials related to symptom screening, assessment, and non-pharmacological management of symptoms. She's currently leading COSA's, Clinical Oncology Society of Australia, development of geriatric oncology clinical guidelines, and co-leading the SPHERE phase 2 pilot cluster randomized controlled trial of a nurse-led triage and assessment system to optimise outcomes for older patients. Before I hand over to Jane, I'd just like to set the scene with just a few minutes and 3 slides to talk about the situation locally here in NEMICS. So within the NEMICS region, which covers approximately 1/3 of metropolitan Melbourne, the VAD is the hospital data system. This is for financial years 2018-2019. During that 12 months, we had about 9,500 individual patients were admitted, and about half were over 70 years of age. In Victoria, patients who have intravenous chemotherapy are counted as an admission, and they were the same day admissions, but particularly if we look on the right there, the overnight or multi-day admissions by age group, you can see that as age increases, a higher proportion of patients will have these overnight or multi-day stays. And so that around half of patients around 60-year age group versus the 80 plus, nearly 70% are requiring overnight and multi-day stays, usually for symptom management or management of toxicities of treatment. Next slide. Not sure if I can change this myself. Oh, good. So looking in terms of the proportion of admissions by tumour stream, so this is the multi-day admissions, and at the bottom that's the percentage of all admissions. So we can see that hematological cancer cases make up the largest group, followed by lung cancer, followed by genitourinary, colorectal, then breast cancer. So that's in the 70-year-old age group. Next slide. And so what are the particular issues in the older age group? Well, multiple comorbidities and associated with that polypharmacy, the setting of undetected cognitive impairment that might be another disorder or sometimes can be associated with the cancer or cancer treatment. Increased risk of complications of whether it be surgery, radiotherapy or chemotherapy, and tied with that decreased functional reserves. So if older patients get sick, they stay sick for longer and they have a challenge returning to pre-treatment function. Whereas a younger patient might bounce back in a week, it might take 2 or 3 months for an older patient. We sometimes are at risk of over-treating patients, and we're also at risk of under-treating patients and denying older patients the potential benefits of treatment. And of particular importance also, clinical trials are generally cater to a population of patients who are fit, relatively young and relatively well, and often do not reflect the sort of outcomes or sort of toxicities that we might expect in an older population. We are cognizant also that in the NEMICS region, our health services, we have no specific geriatric oncology service available. Now, I'm going to hand over to Jane to present for the keynote for the session.
Thank you, Paul, and thanks to the team at NEMICS. I'm delighted to have this opportunity to present to you today. And it's a really nice segue from Paul's presentation with regards to just the changing demographics of the people that we're actually now serving. And I was interested to see that over half of your patients are actually now aged over 70 years of age. But not all of these patients will necessarily be vulnerable. And I think the big thing that I'm really wanting to speak to you today is about actually the opportunities for us as clinicians to think about screening for vulnerability in this older population so that we can actually best identify those who will most benefit from a geriatric assessment. And next slide, please. So I'm going to take you on a very quick overview because I'm really looking forward to having the conversation with Paul, but just to give you an overview and remind you of the importance of screening for vulnerability in older people, but then to also think about what are the optimal screening tools that we could actually all use in clinical practice. And while you don't have a geriatric oncology service, I think there's a real opportunity for all of us as cancer care clinicians to think about the way in which we could play a more active role in identifying the needs of our patients and addressing them. So next slide. Because one of the things that we just think about aging and we think about the older people that we know and the older people we're caring for is not everybody is equal. And, you know, we look at and think about Rupert Murdoch still playing a huge role in terms of leading a global company, right through to the gentleman in aged care who's, you know, requiring quite significant assistance. So functional age, we really, versus chronological age is really the key in terms of cancer care, because in between we'll have people who are fit, well, vulnerable and frail. And so I guess our requirement is really to think about how do we identify the vulnerable, and that's the group we're probably most concerned about in terms of thinking about how we can optimise their cancer treatment. Next slide. And one of the things is that if you look at any of the international guidelines, one of the ways that recommend for optimising cancer treatment is that the gold standard is that everybody would actually have over a certain age, be that 65 or over 70, depending on which guideline it is, would recommend that these patients had a comprehensive geriatric assessment. So if you think about it just from your population, that's 50% of your population actually requires, or, you know, in accordance of fitting with accepted standards, is recommended to have a comprehensive geriatric assessment. And whilst that's a fantastic assessment to have by virtue of the fact that it's multidimensional, it's actually interdisciplinary, and it actually provides a really good overview of the physical, social, psychological functioning of the person, and it is recommended for people aged 70 years and older. It actually takes a reasonable period of time. It actually requires the input of a geriatrician, both to assess the patient, but also in terms of planning and follow-up. And the bottom line is that it's costly and time-consuming. And the other thing is, if we think back to that continuum of aging, or is that not everybody will actually need it. So the trick is to really identify the patient cohort, that 50% of your patients that you're seeing who would actually most benefit by having a more comprehensive geriatric assessment. So next slide. So that's one of the things that we're endeavouring to do as part of developing guidelines for the Clinical Oncology Society of Australia on the Wiki platform. And the first piece of work that we're actually finished is thinking about screening, because one of the things is it's a little bit like asking our patients around symptoms. If we could actually screen to identify older adults who would most benefit from having a comprehensive geriatric assessment, then we will have more efficient use of resources, both time-wise, but also from a cost perspective. So there's been a lot of work done in this area, but there's actually been there's no agreed tool or recommended tool that clinicians should use. So we really set out to identify what were the tools that were currently being used and what's the screening tool that is most likely to identify an older adult with cancer who requires a geriatric assessment. So for many of you, if you're familiar with this work, you will know that in 2015, there was a systematic review undertaken by DaCosta, but we were interested to actually undertake a further update of that systematic review because there had been a large number of studies that had looked at this very issue about what's the best screening tool to be used. So what I wanted to do now was just present you with a quick overview of what we actually found. And this next slide, please. Our work has just been accepted into JAMA Oncology, so it's currently in press, and I'd like to acknowledge the other members of the authors and one of my postdocs who has actually led this review. So what we identified in this review were 12 tools that had been used in various geriatric oncology services. So the majority you will see were actually clinician administered tools. And there was one tool that had to be administered in partnership with the patient and the clinical staff. And there was only one tool that actually really could be administered by the patient, perhaps while they were waiting. So what we found was that there was really wide variability in these tools and their relevance to clinical practice. And what we were really looking for a tool that's got high sensitivity, and that's to ensure that as many older people who are vulnerable are actually captured by the screening tool. We also want a tool that actually had a positive, negative, and a tool that had a negative predictive value. And that was really to ensure that the older adults who were screened using the tool, and the tool would suggest that are fit, are indeed not vulnerable. So we didn't want vulnerable older people to be assessed as being fit. So really we were looking for high sensitivity, but being, the eternal optimists, we're also looking for a tool that wasn't going to sacrifice specificity. So what did we actually find at the end of this review? What we have decided or recommended is that really there's only 2 tools that ought to be considered out of the list of 12, and that is the G8, which is the Geriatric 8 tool. It's a tool that was developed by a team in France. It's being used and validated in 12 studies, geriatric oncology studies. It was designed specifically for a geriatric oncology population. And so what we see there is its acceptable sensitivity and specificity. The other tool that we would recommend for consideration is the Vulnerable Elders Survey. It's a 13-item tool, takes 5 minutes to administer. You know, many of these tools provided no details about how long they took to administer it. And the important thing about this tool, it's been validated for use, that patients with cognition can actually complete themselves. And what we see here is a tool that has acceptable but lower level of sensitivity, but in actual fact quite good and a much higher level of specificity. So we just move down now. I'll take you for a quick overview about what these tools actually look like. So we'll go to the next slide, please. So as I've mentioned, the Geriatric 8 was developed by a French team, and it's based on the mini nutritional assessment, and it's validated for use by a physician or a nurse, and you require no training to be able to use it. It's actually much more sensitive and more reliable for ruling in old adults who may require a comprehensive geriatric assessment. Just looking at the items, it doesn't look like it would actually take that long to complete. Not that that's, as I said, has been reported in the literature. And the other tool which is also worthy of consideration, which is on the next slide, please, is the, as I mentioned earlier, the Vulnerable Elders Survey, which is called the VEST-13. This is an interesting screening tool because it really focuses much more on function and activities of daily living based questions. It asks questions that are really easy for patients to actually answer themselves, and that's why it can be self-administered, and it's more specific, so it's more reliable for ruling out fit patients from receiving an unnecessary comprehensive geriatric assessment if they don't actually require it. So I guess probably just next slide, please. In conclusion, and I've highlighted the references there for you, is that implementing really either of these screening tools into clinical practice will actually assist you to identify potentially vulnerable older people with cancer and enable you to think about either referring them on or undertaking a geriatric assessment, which doesn't actually require a geriatrician, or referring them on to a geriatrician for a comprehensive geriatric assessment, and where it provides an opportunity for us as clinicians to think about and identify their unmet needs, which may be physical, they could be psychological, they could be financial, social. And if we think about older people, quite often they're the carer, particularly if they've got a spouse or a partner. And exploring the benefits, one of the final pieces of research that is yet to be undertaken, but there's a couple of studies at the moment that are underway, is actually looking at integrating both the VES and the G8. So getting the patient to complete the VES in the waiting room, and then actually the clinician administering the G8 when they see the patient face to face. So next slide. So in conclusion, I would just say actually use a tool, use either the G8 or the Vulnerable Elders Survey. There are a number of cancer services across Australia who have implemented these tools into their oncology electronic medical records, which enables screening to happen really quite clearly. So back to Paul, and happy to have a conversation with you, Paul, about, you know, opportunities to think about screening in clinical practice.
Thank you very much, Jane. I note with some interest the unfortunately named third survey up there, the frailty criteria. So I'm glad we're not using that one.
Yeah.
Now, just from a kind of practical point of view, in terms of how do we go about setting this up? Should we start in a particular area in terms of where we're going to see the sort of a high proportion of frail patients? Who should be organising all of this? Do we need to recruit someone, or do we get clinicians skilled up? Those sort of practical considerations.
Yeah, thank you. And I think there's many roads that lead to Rome. And I guess the first question I would say to you, if half of your patients are over 70 years of age, is geriatric oncology core business for your team? So I think that's probably the question for you as a team to ask. And then there may be some areas where some of the populations are where the majority of your over 70-year-old patients are located. And that to me would be the ideal starting point to pilot actually a screening tool. I think the other thing is to think about whether you actually want it to be patient administered or clinician administered. Be patient administered. You could be actually thinking about getting your patients to complete it either before they come to the clinic if they have, some degree of computer literacy. You could be getting them to do it online, or you could be getting them to do it in the waiting room. But the important thing, I think, is for the clinician, either the treating clinician to be actually thinking about the potential or the benefits of actually referring the patient on for a comprehensive geriatric assessment. But when I think about screening in geriatric oncology, and I guess this is really shaped by my nursing, I think about there's two requirements about screening. One is actually just to get an idea if people may be vulnerable, and then to assess where that vulnerability might be. And so one part may be for you as the treating physician, you may want to know more about the patient's ability to cope with standardised treatment, or whether the treatment actually needs to be modified. And that's to address the issue that you mentioned earlier, because no clinician wants to overtreat somebody, but by the same token, you don't want to undertreat. But I guess for me, from a nursing and allied health perspective, I think that if we understood what people, where their vulnerabilities were in terms of being able to maintain their level of function and their activities of daily living and their social commitments, that in actual fact, we may be able to support them to be able to optimise their treatment. So you as the treating clinician can focus on the treatment, but then the rest of the team can actually focus on supporting the older person within the context of their usual life to be able to cope with treatment and not to suffer unnecessarily. I think the other thing is often when we're doing screening, and particularly if we go, because it prompts us to think about the other assessments, we find out all sorts of things about older people, and we need to remember that many of these older people will have other responsibilities. They may be caring for grandchildren, they may actually be caring for an unwell partner, or a child, an adult child with a disability, and all of that really impacts on their ability to be able to cope.
So, and where in the pathway would you suggest that we should consider screening? We have some considerable experience of screening for supportive care needs, and it's often quite difficult at point of first contact to screen. We often are successful if patients are coming in the day oncology or radiotherapy, we can capture them, as it were, but because there are quite a number of entry points in different clinics, it can be quite tricky. Should it be ideally at point of first contact, or sort of at the time of deciding exactly what treatment the person should have? Have you got some suggestions there?
Yeah, you've really raised an important question, because often these patients, when they first come in, are just so totally overwhelmed. And I guess it's deciding when it's going to be of most value and how that information is going to be used. I think from my perspective, the sooner somebody's screened to identify where there may be some risk factors, the sooner we can actually start to put appropriate supports in place to enable them to either cope with their treatment or also to inform the treating team. I think the other thing is about screening, it's quite likely that it's going to have to be implemented at multiple junctions, because you may have someone who comes in who's really quite fit, and then as they're actually having treatment, they're starting to deteriorate, or they're finding it really hard to cope, and you will need to actually reassess then. I guess for you as a team, it's thinking about how does it get integrated with your routine. I'm wanting to say distress screening, but they may be my words, not yours, but the psychosocial screening that you're doing for your other patients. I think the other thing is that you know, in oncology, and I'm going to speak to nursing now, I think depending on where we're working in oncology, you know, there are real opportunities for nurses to think beyond just the administration of chemotherapy agents, and to be actually undertaking much more formalised screening and assessment. You know, I often think it's a travesty that often we have nurses who not necessarily sort of have the time to be able to really be comprehensively assessing their patients when they come in. I think the other thing that is really a health service issue is that many of these patients will be seen for the first time in outpatients clinic. And I can't comment on your service, but one of the things that has struck me in ambulatory care, or particularly where doctors are actually reviewing patients and families in the outpatient clinic, is that we have had registered nurses removed, or enrolled nurses removed from that environment. So often you don't actually have access to nursing care or a nursing assessment, yet that would be the ideal opportunity to be able to do that when patients are actually presenting, waiting to be seen by the medical specialist. So I don't know, do you have nurses in your outpatient clinic, Paul, when you're seeing your patients, reviewing them?
We do have nurses, but they don't take that function, unfortunately. They're more a kind of administrative function.
Yeah, and see, that's sort of, if I think, I'm showing my age now, but if I think back to, you know, probably even, you know, a decade ago, there were probably a higher ratio of registered nurses, or even the presence of a registered nurse in ambulatory care. And to me, in some ways, it is a real travesty, but that, you know, nursing clinical assessment role has actually been removed from that setting. And if you think about the way many geriatric oncology clinics are set up, often they're set up where the patient will actually see multiple health professionals at the same time, not necessarily the patient's not necessarily been asked the same question, but the information is being shared between the clinicians, so they're actually able to make a better assessment. And I think that nursing has a really key role to play in that setting. And many of the geriatric oncology programs have actually been led by a nurse practitioner and or a senior clinical nurse who is undertaking that assessment and then really informing the other members of the team. But remembering, not all of the patients, all of the patients will actually need that detailed level of assessment, and that's why the screening is really so critical to be able to triage out.
Now, I've got 3 questions here. I don't think we'll get through all 3, but there's one that is around the issue, how do you get tips in terms of how to get your health service, whose human and financial resources are stretched, to take on board the geriatric assessments process.
Yeah, it's a real challenge, and I think it has to be, you know, like any change, it actually has to be a shared vision and a commitment that if 50% of your clients are over 50, over 70, then are they a priority, or are you just going to carry on doing what you're doing? And what are we going to give up? And what are we going to change to enable that to happen? The interesting thing about screening, it actually doesn't take a long period of time. However, you have to be able to act on it. So if you've got a positive screen that was suggested of vulnerability, then you need to have a system in place to be able to refer on. And it does actually really have resource implications. But actually treating older people without understanding their physical, social and psychological needs also has resource implications. Imagine if we actually screened and we only needed to undertake a comprehensive geriatric assessment, perhaps on, you know, 50% of the over 70-year-olds that you're actually seeing, and we were able to prevent them from being admitted because we provided better supports for them at home to be able to cope. We actually understood that they were caring for their wife. We arranged an ACAT assessment. We linked them in with their GP. We made sure that they actually had a referral to community nursing. We got in home care. So there's all of those things. I know it's not rocket science, it's really quite simple, but they're often the things that these older people need to be able to cope with their treatment regimes.
Thank you very much, Jane. We'll have to leave it at that. I mean, at the moment, in terms of the COVID situation, and certainly in Victoria, in terms of doing so many telephone and telehealth, it's particularly difficult because you know, basically, I like to see the patient walking in the door.
Yeah.
At least a starting point to know what functional level they're at. And if you're just at the end of the telephone, you don't even know that.
Yeah, so Paul, you would have loved our study that we've just completed, because one of the things that we did was got nurses to do standardised geriatric assessments of older people using Interray that were fed to the clinicians. So that was the study that we've just actually finished as a pilot. And that is actually really important. So before you saw the older person, you would actually have, even if you were doing it in telehealth, you would actually have the Interray, which is standardized geriatric assessment tailored to specific populations. And so there's a suite of assessments that nurses can actually do related to older people with cancer, and you would have that information. It's not quite the same as laying on the hands as the clinician, but at least you would actually have that information. And I know the use of standardized assessments using Interray has transformed the way, say, Professor Len Gray runs his geriatric services from Princess Alexandra in Brisbane, because essentially he's doing what we're doing. He's running it from a TV studio where every patient he's seeing, regardless of whether they're in a nursing home, in the community at Mount Isa, actually has a standardized Interray assessment undertaken by a nurse. So there are lots of solutions, I think, but it just requires us to probably have the commitment and to you know, think differently about the way in which we're doing. And it probably does require us to give something else up, because I'm not sure we can all do more with less. And particularly, I'm sure in Victoria at the moment, you're all being asked to do that. And, you know, it's challenging.
Thank you very much, Jane. We now have, I think, more than 10 questions, but they will have to wait for later. Just you've obviously stirred up a bit of enthusiasm and interest and hopefully some action in this area. Yeah. So thank you very much for your...
So look out for our paper, which should be out later on. And I'm hopeful by the end of the year, the COSA guidelines will be up on the wiki platform.
Thank you. Thank you. Now, just to close, thank you, Jane, and thank you for the NEMICS team in terms of presentations. Our annual report for the 2019-2020 year is on our website, and we had just briefly a few things that happened during the year other than COVID. We had a regional service planning event that kicked off work in refining specialist referral pathways and care coordination and cancer care outside the hospital. Consumer-driven projects, particularly the My Cancer Care record, involved in a hackathon, great language there, but better ways to manage all the information. A new cancer plan is coming in Victoria in October this year, so we're looking forward to that. And there's some new branding for the integrated cancer services that across Victoria that I suppose particularly emphasises that each of the integrated cancer services is part of a whole for the state. And thank you to all the consumers and the clinicians involved in NEMICS activities through the year. Now we're going to send out a short evaluation via SurveyMonkey, so we'd be very keen for your feedback, and the team will do their best to provide some answers to questions which we haven't dealt with. Thank you very much, and thank you for your attendance.